Dr. Are you okay if we go ahead and get started?
Yeah.
Okay. So I wanted to say again, good morning, everybody. Welcome to part 2 of the ANPA COVID-19 Vaccine Conference. I am the membership committee chair, Dr. Susan Anyanwoke, coming to you from Houston. I wanted to, again, take a minute as last time to, one, wish everybody a happy holidays. I hope your Christmas was fantastic, and a happy new year. And then to remind everybody, my purpose essentially as the membership chair is to remind everybody a few things. One, for those who are on the call where this is your first conference and you may not be an ANPA member, ANPA has a very rich history of advocacy and philanthropy. It's over 25 years old. We have over 20 chapters. ANPA is committed to evolution, to modernization, and to giving a platform for Nigerian physicians in the Americas, as well as Nigerians back home. So we really need you to be a part of us, help us advance our mission and continue to grow as we are at the end of the year. For those who are in the mind of charitable givings, please be aware that you can make your donations to ANPA. Furthermore, as we are about to transition into a new year, this is a call for membership dues renewals. You will be seeing multiple emails and prompts from that. A number of you have probably seen the fantastic video provided by our treasurer, Dr. Cliff Eke, reminding everybody to, again, make your donations and your dues to ANPA. These donations and dues really help us further our mission, and so it's very, very important to our cause. So what overall is our ask, aside from giving your dues and your donations, help us continue to grow. We want you to definitely share ANPA and what we're doing with your platform. We recently have had the privilege of working with a company that has shown us our true potential. And there are a lot of Nigerian physicians out there who may be aware of ANPA and not a part of it yet, or who are not even aware of ANPA. So if you have these people in your network, we ask that you share the wonderful things that ANPA has provided, such as this conference. And lastly, I'll be presenting this for the IT committee chair, as she won't be available today. In terms of communication, be aware that we have a lot of different ways that you can communicate with leadership and also with other ANPA members throughout the nation. We have our ANPA e-groups and our WhatsApp groups. There are also our social media platforms. We have on Instagram, ANPA_national, Facebook, ANPA National, and on Twitter, ANPA blog. As it pertains to COVID-19 and COVID-19 resources, please be advised that our website, anpa.org, has a plethora of resources for you regarding COVID, including vaccine information. You can find that information there, as well as more information about ANPA. Without further ado, I will be introducing, again, I have the pleasure of introducing one of the co-moderators for today. As I said before, he is a board-certified, fellowship-trained orthopedic surgeon. He is a member of the Georgetown MedStar Orthopedic Institute, an avid philanthropist. He's formed the CAS, which is the Center for Advanced Specialty Surgery hospital in Nigeria. He is also the founder of Operation Stand, Walk, Run. He is a humanitarian award recipient, and he is the chair of ANPA DMV. He is somebody to look up to. I give you Dr. Onyike.
Thanks so much, Susan. Very, very kind words, much appreciated. Let me first of all say Merry Christmas weekend to everybody. Happy Boxing Day, as we say at home. Welcome ANPA members, colleagues. We also have visitors and guests here today. But I want to thank everybody for making time to join us on a holiday weekend. As we always know with Zoom, etiquette is to turn off your mic. So please mute your microphones. Feel free to use the chat functions as we progress through the discussion today. Personally, I'm delighted. I appreciate the honor of being a participant in this as the moderator. Those of us who were with us last week would agree that it was very well received, very well done, informative, and confidence inspiring for those who may have been somewhat skeptical about the vaccine. We're going to do more of the same this week and add some nuances that were not touched on. It's going to be both broad and deep because we have outstanding panelists and guest speakers. I am Onyike, as already mentioned. I'm an orthopedic surgeon in the midst of infectious disease experts. So my job is really to provide perspective on the bone and hopefully facilitate the discussion. But I'm very honored. It'll be a faux pas without mentioning our president, ANPA president, current president, Dr. Chris Okunseri, who was also with us last week. I also want to acknowledge Gertrude Anyanwoke, who is the chair of the COVID-19 task force and the infectious disease committee, among other things. She is instrumental in putting this together. Thank you also to the membership committee for their participation in this effort, as well as a lot of behind the scenes work by our secretariat led by Letitia Dutch. I'm going to allow our president to make a few opening remarks, and then we will proceed with the rest of the talk. Thank you, Dr. Chris. You can unmute your mic.
Thanks, Dr. Aham. I would also want to quickly echo all the thank yous that has been shared by all previous speakers, the Dr. Susan Edionwe, Dr. Aham Onyike, but I want to also quickly say, on behalf of our great organizations, ESCO, myself as the president, the immediate past president, Dr. Charmaine Emelife, the treasurer, Dr. Cliff Eke, and the president-elect, Dr. Chichi Ayangu, we thank the COVID task force chair, Dr. Gertrude Anyanwoke, and the team that she has put together to continue to educate us on this vaccine and all the other efforts that her team is working on to continue to position our great organization in a place where we can all be proud to say we are out there setting the standard or maintaining the standard or being a flag bearer on how to help address the issue of COVID, whether here in the United States or back in Nigeria. So I thank all ANPA members and non-ANPA members who are here for your continuous participation and believing in this team and in the panelists. I again appreciate members of the panel who continue to, commit and share their knowledge and expertise with all of us. And on behalf of our great organization, I thank you and wish each and every one of us Merry Christmas, stay safe, and a prosperous New Year. Thank you very much. We're not boxing today, like Aham said, but it's a boxing day.
I always wondered what the meaning of Boxing Day means, but maybe Google can help us with that.
No, I'll help you. That's why you box your gifts that you got yesterday.
I thought you unboxed the gifts, not box them.
In the English way, you box them.
Okay.
You put them in your portmanteau.
In the absence of competing answers, we'll accept Cliff's as the answer. We'd also want to mention that we are joined today by some special guests, including the director/head of the Family Health Department at the Federal Medical, Ministry of Health, the Federal Ministry of Health in Nigeria, Dr. Adedeji. Dr. Adedeji, if you're here, you can indicate so through the chat. We'll appreciate it. Also, if she's not here, she'll join us shortly, I expect. And then also Mrs. Ifueko Okuro, who is a representative for a nonprofit organization, that does a lot of vaccine work in Nigeria. In addition, special guests expected to join us today from the WHO and Gavi, which is the Global Alliance for Vaccines and Immunizations. They obviously have a reputation and experience in vaccine distribution in sub-Saharan Africa, including Nigeria. So that perspective hopefully will be something that we can delve into on this discussion today. Once again, we have great panelists. Those of you who were here last week will agree with me. They are infectious disease doctors who are in the thick of it at different areas, research, clinical care, pharmaceutical, and policy as it pertains to COVID-19 and what's going on in this country. Of course, America remains the epicenter of the pandemic, both to the bad and the highest number of cases, highest number of deaths, but also in the good with breakthrough discoveries, treatments, and most recently, vaccines. So those are some of the discussions that we're going to have today, led by Dr. Gertrude Anyanwoke, who at this point probably does not need introduction. She is a familiar face, a reliable expert within our ranks. Since the beginning of the pandemic, Gertie has risen to the front in educating Nigerians in the medical community and outside in Nigeria and also here in the diaspora. Gertie is the chair of the ANPA Louisiana chapter, the chair of the ANPA COVID-19 task force and the infectious disease committees. In her professional practice, she's the medical director of the Infectious Disease Associates of Baton Rouge and the Multi-Specialty Care Center, also of Baton Rouge. Without further ado, Gertie will go ahead and make some remarks. Thank you.
Thank you so much, Aham. Very flattering, very flattering. Without further ado, I'll launch straight to introduce our first panelist of the day. He is my boss, Dr. Adedeji Adefuye. He's an infectious disease physician. He's also an epidemiologist. He's currently an executive medical director at Takeda Pharmaceuticals. Dr. Adedeji serves on the Pharmaceutical Industry Consortium on COVID-19 and National Institute of Allergy and Infectious Diseases COVID-19 Immunoglobulin Alliance. He is the immediate past chairman of the ANPA Infectious Disease Committee. Dr. Adefuye, you're welcome, sir.
Thank you.
Okay, thanks, Gertie. Also joining us as a panelist this week, our speaker last week as a guest speaker, he gave a lecture on demonstrated mastery of the COVID-19 vaccine. He joins us again today, Dr. Obi Nnedu. Dr. Nnedu has let us know that he's on call and may be pulled out at any time, but we're taking our chances considering that he's an infectious disease doctor and we don't expect infectious disease emergencies to emerge on the holiday weekend. So I'm confident that his call will not be disruptive. But anyway, Dr. Obi Nnedu, our speaker last week, is here with us again today, this time as a panelist. He is the chair of the family practice program, infectious disease program at Oshner. He's a fellow of the Infectious Disease Society of America, fellowship trained at the Washington University. He is a member of the Coronavirus Prevention Network and has demonstrated expertise in numerous policy initiatives through that position. He's a clinical investigator in COVID-19 trials, and again, will be with us today. Dr. Nnedu will be welcome.
Thank you very much.
And Dr. Anyanwoke will introduce our speaker today.
Yeah, we have today our speaker is no other person but Professor Ofotokun, who is a professor of medicine. Professor Ofotokun has a lot to do with HIV and HIV care. His resume is very long. If I start, we will not finish until the end of this program. So I'm going to be brief. Professor Ofotokun is a professor of medicine at Emory University School of Medicine. He's member FDA Antimicrobial Advisory Committee. He's member of the Infectious Disease Society of America and HIV-ME governing boards. He's member of the NIH Infectious Disease Clinical Research Consortium Leadership Group, coordinating the COVID-19 vaccines and therapeutic trials. Ladies and gentlemen, I give you our presenter today, Professor Igo Ofotokun.
Thank you, Dr. Anyanwoke. I'm going to try and share my slide. Can the host give me the ability to share my slide? So it's a host disabled participant screen sharing.
Latisha.
Hi, I'm sorry, I am giving you access now.
Okay, good, very good. So while we wait for my slide, I really want to thank all of you, and especially my colleague in the COVID-19 task force and the ANPA infectious diseases working group. It's been a pleasure working with this group throughout this pandemic, really brainstorming and figuring out a way to educate our community about what is going on in the field. So most of what I'm going to be sharing with you today is really our experience, some of the things that we have experienced in the process of developing both the vaccine as well as the therapeutics for the COVID-19 vaccine since the beginning of the pandemic, towards the beginning of this year, late 2019. So let me share my slide here. Thank you. Can you all see my slide?
Yes, sir.
Okay, so let me go into presenters mode. Awesome. So what I thought I should do today was to really continue the dialogue we started last week. I don't have a specific title. I have titled it ANPA COVID-19 Vaccines Session 2. We had Session 1 last week. And part of what I thought was maybe relevant is to really begin a series of dialogue by answering some of the key questions that people have about the COVID-19 with particular emphasis on the vaccine. So I'm going to be very brief, and I have listed a series of 10 commonly asked questions that I want to address from what we know from the published literature and also from our experience in developing the vaccine or the various vaccine, including using the Pfizer vaccine for which we have the most data as an example. So here on the slide, you can see the list of questions that I thought we should at least address head on. And many of these were some of the questions that were raised during our discussion last week that I thought we didn't adequately discuss. So the first one is, can you hear me? Can you hear me?
Yes, we can.
Okay, great. Yes. So the first question on this list is, how does the vaccine work? Was the process of developing the vaccine rushed? Was our population well represented in the clinical trials? Is the vaccine effective in all population? Should one take the vaccine if one already had COVID-19? What about the new UK mutant strains in the news? What are the common side effects? Tell me more about the rare side effects. Tell me more about the stability of the various vaccines. Will all COVID-19 vaccines be mRNA vaccines? So let's begin with the first questions. So how does the vaccine work? So we know that, again, we have to really, one of the things I really want us to do today is to really acknowledge the contribution of Africans to vaccine development in general. Many of you, if you do follow medical history, the first vaccine that was ever developed in history of vaccinology was a smallpox vaccine. And you would all remember that the smallpox vaccine was actually an idea that came from African slaves.
Yeah.
So when we, during in the 1800s, early 1800s, 1700s, smallpox was ravaging the world. It was the pandemic of the world. A lot of people were dying from smallpox. Here in the US, African slaves recognized that back home in West Africa in particular, that when people had smallpox, if you take a little bit of that pus from somebody that has smallpox and you inoculate that piece to somebody that has not been exposed, that small, you take the pus and you expose somebody, you do this, the usual scarification that they do at home, and you expose that pus to that scarification, and that led to protection against smallpox. And that was kind of how many people were protected from smallpox in the United States. And that was kind of how the history of smallpox was the first vaccine ever that was developed. And the idea actually of vaccinology, that if you expose somebody to a small amount of the pathogen, a deformed amount of the pathogen, the body will eventually develop some kind of resistance that if that person is exposed to the infection, they will be protected. That was the history of smallpox. And so the various way vaccine works, if you look at this slide, the first one, and that this was the first way, and this was the one that actually came from West Africa, where you take a small piece of the virus or the pathogen that is inactivated and you expose it to somebody. And that person then recognizes that virus. Excuse me here. Okay, so the body recognizes it, develop both antibody as well as T-mediated cell immunity against the pathogen. The second way a vaccine works is that you can, instead of taking this whole virus organism, you can take a piece of the organism, just a small piece of it, and then you expose that piece called the subunit, which will be a protein subunit. You expose that piece, you give that piece to somebody who is naive to the infection, and then they develop immunity to the whole, to subsequent infection. The other way is to get what they call the virus-like particles, something that looks like the virus, but it's not a virus. You have a combination of the virus and you deliver it. The fourth way is actually you take the genetic material of the virus, you deform the genetic material in such a way that it replicates but cannot cause infection, and then you insert it into another virus, usually adenovirus, and then you deliver that the product to somebody. And then that product, that virus replicate, but is not able to cause disease. And so the latest is this DNA or RNA, nucleic acid vaccine, which is kind of what we now have today, messenger RNA vaccine. So the reason why it was possible to do this was, if you all remember in the news in the 90s, 80s, and 90s, the entire scientific community undertook the deciphering the genome project. So we were able to encode the entire human genome, and we did it for a number of viruses, a number of bacteria. And so what happens is that you have the blueprint for the particular organism, and in the case of COVID-19 virus, the SARS-CoV-2 virus, within a few days, weeks of discovering the virus, because of the technology for the human, for the genome, the fact that we can now really decipher, we can break down the component of the gene. And in the case of the COVID virus, it's about only 15 genes. They were able to quickly decode the genetic code for the virus. And by January 10th, we knew what the genetic code for the entire virus was. And it was very easy to take a piece of that genetic code and then make a piece of protein from that virus. So in this case, we took the what we call the spike protein, which is a very small part of the protein. And people realized that the body is able to develop antibody to the spike protein. And so we developed the genetic code for the spike protein. And what we then did was take the genetic code, which is messenger RNA, package it in a lipid nanoparticle. And this was to keep the RNA stable and also to allow the RNA to get into the cell. So you deliver the RNA, and the RNA then takes advantage of the protein factory. So we all have our protein factory in the cytoplasms of the cells, which include what they call the Golgi apparatus, the reticular endothelial system. So the RNA gets into this protein manufacturing factor, and then this ribonucleic acid then convert this RNA into the template from which the spike protein is produced. So the spike protein is no longer just the spike protein of the virus. You actually trick the body to make the spike protein. Spike protein is released into the system. And then what happens is that the body recognizes as the spike protein, as it will recognize the spike protein of natural infection. it develops both cell-mediated as well as antibody-mediated immunity against the spike protein. All of this process usually takes between 7 to 14 days. So the two things we look for when we are evaluating a vaccine is the immunogenicity of the vaccine, which is the good effect, the ability for the body to actually produce the protective antibody, as well as the T-cell-mediated immunity. The other thing we worry about is the reactogenicity, which is the side effect, which is probably what we'll focus more on today, because last week we did talk about some of the efficacy of the virus. So the reactogenicity. And the reason why we have reaction is because not only do you have the virus is often packaged, like we said, it's packaged in this lipid nanoparticle. And part of the component of this lipid nanoparticle is this complex lipid known as polyethylene glycol, the PEG protein. So the body also develop antibody to this PEG protein, leads to reactogenicity. And we'll talk about this a little more later. There are two other concepts I just want to mention in case you hear about this in the discussion of the vaccine, is this the antibody-dependent enhancement of infection. So antibody-dependent enhancement of infection means that you give somebody the vaccine, instead of protecting you against the infection, it increases your risk of the infection. We see this more commonly with all this inactivated virus technology, and we've not seen that with this current RNA vaccine, both the Pfizer and the Moderna vaccine. And then the last thing I just wanted to mention is this, what they call the VAD, the virus-associated enhanced respiratory distress. So this is a situation where you develop neutralizing antibody, but the antibody is not able to neutralize the virus. So you have what you call antibody antigen, immune complex deposition, which triggers the body to produce what they call Th2 cells immune pathway that leads to production of IL-4, histamine release, a lot of mast cell that leads to asthma-like reaction. It's something that we have not seen with this vaccine, but I thought I should bring it up in case sometimes in the discussion of the side effect of the vaccine, these two phenomena are mentioned, but they are phenomena that we've not observed. And they're usually more common with respiratory viruses, vaccines that are developed against respiratory viruses like measles, as well as RSV viruses. It's something that we were concerned at the beginning of the development of vaccine for COVID-19, but something that we have not observed. So the next thing the next question I wanted us to go through is, was the process rushed? So we have to think about how RNA vaccine development started. So many of us may be or may not be familiar with these two names, individuals that I have represented on this slide. So Dr. Carrico is a Hungarian biochemist who immigrated to the US sometime in the early 90s, became a faculty at the University of Pennsylvania, UPenn. So Dr. Carrico spent her entire life working on mRNA platform for therapy. So when mRNA, as we mentioned last year, I think the first time the concept of mRNA was introduced into therapy was sometime in 1989. So the problem with the mRNA platform was that the mRNA, remember mRNA, the RNA ribonucleic acid, they are the building block of life. So there are 5 types of ribonucleic acid. 4 of them are used for the synthesis of RNA. The other 4, they overlap for the synthesis of DNA. So when you couple all of these ribonucleic acid together, and they are very unstable in the first place, so they degrade very rapidly. And then when you give it as a therapeutic, it was developed for treatment of cancer, and was also developed for vaccine against Zika, and I think against RSV and a number of other viruses. The problem was that not only was it unstable, is that when you give it, because you have so many components, you have four different nucleic acid, they develop their own immune response. So they are not able to produce the protein that you want them to produce, that you're targeting for the body to develop immune response to. So what happened was that Dr. Carrico was able to trick the RNA platform and made it less immunogenic, so you can actually deliver it to the body, and it will then produce the protein that you want the platform to produce. And so they published a paper sometime in 2000, I think around 2004, 2005. Nobody really thought much about that work until about 2 years, the beginning of last year, or towards the end of last year, when the COVID-19 pandemic started, and somebody actually reached out to them. So she's now the vice president for BioNTech, which is the company that worked with Pfizer to produce the Pfizer vaccine. The other person I really want you to remember in this conversation is Dr. Colbert. So Dr. Colbert is with the Vaccine Research Center at the NIH. Dr. Colbert worked with Operation Warp Speed to develop the Moderna vaccine. So there were involvement of our people, immigrant as well as African-American, in the development of these vaccines. And if you look at the number of people that have been exposed, been given these vaccines so far, you're probably getting close to 200,000 people that have received some form of COVID vaccine in terms of during the clinical trials. So the work that was published, the Pfizer vaccine that was published in the New England Journal of Medicine about a week and a half ago, they recruited over 44,000 people, but 37,000 of them were evaluable in the paper that they published that Dr. Nnedu reviewed very nicely with us last week. The Moderna vaccine trial is over. They recruited precisely 30,400 individuals were recruited into the Moderna vaccine. So AstraZeneca is currently recruiting. As of last week, their plan is to recruit about 30,000 people in the US. Before the holiday, they had recruited close to 25,000. So before the end of the year, they should be completely done with their study. Janssen, which is a component of Johnson & Johnson, have completed their recruitment. They recruited 60,000 individuals that were exposed in their clinical trials. So Novavax will start recruiting next week, and they plan to recruit between 30 to 45,000 individuals. And Sanofi is currently on hold. Hopefully sometime early next year, they will be back in business. And so the point I'm trying to make here is that, first, a lot of people have been exposed to this vaccine, and we will review some of the safety and some of the safety data shortly. Two, immigrants were involved in development of this technology. African-American, Blacks like us were also involved in the development of this technology. All of these should be reassuring. I know there's a lot of concern. People have mentioned the story, the experience with Tuskegee, and a number of other experiences of how Blacks were marginalized, were used for as guinea pigs. But that is not the case with the development of these vaccines. The other thing I want to mention is that the process was not rushed. mRNA vaccine has been the technology has been refined since 1989. So it's not completely a new technology or platform. And then the third thing is that the reason why things really went very fast was that the federal government invested a lot of money through Operation Warp Speed. So Operation Warp Speed is this body that the federal government put together that included researchers from NIH, the private sector, and then, of course, people within the human health services. The government invested over $10 billion, and all of these companies the product were risk produced. So they were given money to develop and to produce this product. They were paid ahead of time. If they succeeded, if they succeeded or if they failed, they had nothing to lose. They were paid ahead of time, so they were not carrying any risk. So it was, if you hear Attorney Fauci speak about this, that we risk produce this drug. So these drugs were already produced, they were manufactured, the vaccine, even before the trials were completed. So how representative are the clinical trials? So we look, and I think sometimes one of the concerns we have is that where our people represented in these studies. So we have been involved in all of the operational design of all the big vaccine trials in the US, the Moderna, the AstraZeneca, the Novavax, the Johnson & Johnson, and also working with the Sanofi. So here is the data from the Moderna in the New England Journal article that was published. 82% of all the people that were recruited were white, 10% were African Americans or Black, 26% were Hispanic. Hispanic were more because they recruited from Brazil and Argentina. And also you look at the proportion, I mean, the proportion of Blacks in this country, I think is somewhere between 12 or 13%. Proportion of Hispanic is about 15%. So there's a reasonably fair representation of all groups in the trial. And when Moderna, I have seen the data from Moderna, I've also seen the data that is accruing from AstraZeneca as well as Johnson. All of the data are kind of similar to what you see here. There's a fairly robust representation of people of color, brown and Black individuals. And if you look at the distribution by sex, you know, almost equal number of men and women, 49% women, female, 51% men. How the efficacy of the vaccine in the various demographics. So we know that the overall efficacy of the vaccine is about 95%. So if you look at the ratio efficacy, so this is again from using the Pfizer vaccine, you see that among whites who received the vaccine, it was 95.2% effective. Among Hispanic, 94.4% effective. Every Black person that was vaccinated was protected, 100% effective. And then if you look at the various age groups, you can see that from the very young, 16 to 55, all the way to 75, anything that, I mean, an efficacy of 95% is just amazing. So we can see that it was, you know, just as effective regardless of age. And also in men and women, you see the efficacy is equally outstanding. So the other question that we hear commonly about is whether people should be vaccinated if they have had the COVID infection, if they've recovered, if they've recovered from a COVID vaccine, should they get the vaccine? So the reason why this question arose was this data from the UK. So this is a preprint, it's not been published yet. So what they did was that within 30 days of infection, they got the serum from people who had COVID vaccine. And they followed them over a period of 90 days, 3 months. And so what they saw, whether they were looking at men or women, everybody, they saw this, you know, gradual decline in the level of antibody. So these were antibody against the spike protein, which has been known to be neutralizing. And they saw there was almost close to 30% reduction in the level of antibody after the initial infection within a period of 90 days. So note that there were about 17,000 people that were assessed in this study. Then more recently, this was in December 4th, about 2-3 weeks ago in Science, and this is another study that came out from the US. These people did exactly the same study that was done in Europe. They collected serum from people who were infected with COVID within 30 days during the acute infection, and they followed them for a period of 6 months. And what they found out was that over 90% of individuals, as you can see on this slide, had antibody level that were above what is considered to be protective. Again, so this is a very conflicting study. So here is a study that says if you get COVID, you will have there will be decrease in your antibody level. And then another study, and again, these were large numbers. I think these were also close to 15,000 people that were assessed in this study. And they saw that the level of antibody was protective in over 90% of individuals. And then as I was preparing for this talk on Wednesday, there was this study that came out from the UK, looking at people that have had COVID-19 to see whether they will have reinfection. So this study that is represented on this figure here, they took healthcare workers. Here they had over 30 or over large number of healthcare workers, and they did serology to see if they have been exposed to COVID-19. And they did serology to the spike protein. They also did serology, looked at antibody to the nucleocapsid protein. And then they followed this individual. So if you had antibody at the beginning of the study, and you're shown here in this what looks like orange, and then if you don't have antibody, you're shown in orange. If you had antibody, you're shown in blue. And then they followed them over a period from April to November, and they were looking for those who would develop infection. And so what they saw here was that if you are naive, you've never been exposed to COVID-19, you will develop infection. You see the rate of infection rises by hundreds of them, over close to 200 people develop new infection. But if you have been exposed and you have antibody to the spike protein or the nucleocapsid protein, over a period of 5 months, there was no infection. And then 2 individuals eventually developed evidence of infection. They were looking at the RT-PCR using the nasal swab, and those people had asymptomatic infection. And so what they concluded was that if you have had COVID, you're likely to be protected, and the risk of reinfection is not completely zero, but if you have reinfection, that infection is likely to be mild. And so putting all this data together, the CDC currently advises that people with a known history of COVID-19 may wait for up to 90 days after prior infection to get vaccinated, if they prefer to do so. So we're recommending vaccine if you've been exposed to COVID-19, but you have the luxury. You don't have to be immediately vaccinated if you choose not to be immediately vaccinated. So what about the new strains of the virus being reported in UK as well as in South Africa? So one thing I want to say is that viruses in general mutate. I mean, that is the reason we don't have a vaccine for HIV just yet. The reason we don't have an effective vaccine for hepatitis C, because viruses in general mutate. We, since the beginning of the epidemic, COVID-19 epidemics, there have been close to 4,000 different mutant strains of the COVID-19 SARS-CoV-2 virus. Why these new strains were concerning is that a lot of these are happening. If you look at the subunit, the genomic material, the genome of the virus, these mutations are occurring at the receptor binding site. So this is the receptor, this site is the receptor binding site of the spike protein. Remember that the vaccine we currently have is developed, the epitope for that vaccine is targeted at, it is located at the receptor binding site. So there were 2 things. Is this mutant, is it more virulent, or will it also escape the vaccine? So far from what we know from data that is coming from South Africa, as well as the UK, there is not more deadly, but it seems like it's about 50 to 70% more easily transmissible. So there are 4 of these mutations. So there's the K401N mutation of the receptor at the receptor binding site, receptor binding domain. There's the E484K mutation, and then more importantly, the N501Y mutation. And then recently, I think it was an email that Getty sent to us. This strain here, the D614G, was recognized in Nigeria. And so the question is, first of all, it's not more deadly. It appears to be more rapidly, more easily transmissible. And will it escape the vaccine that we currently have? So remember, everything COVID moves at the speed of light. At the speed of light. A few days ago, this was on Wednesday, this guy, Menacheri lab, actually took antibody against the the native spike protein and expose them to this mutant spike protein. And what he found out was that in the presence of this native antibody to the native spike, which is what we developed our vaccine against, that it actually neutralizes the spike protein from this mutant from both either UK or the South Africa. So we think that the vaccine would have effectiveness against this mutant strain. But notwithstanding, I read in the news was this yesterday, Pfizer was saying that even if it is not effective, given the rapidity with which we manufacture this vaccine, they are able to produce new vaccine within 6 weeks against this mutant strain. So what are the side effects of this of the vaccine? So the two we have so far is the Pfizer and the Moderna that we have data on so far, because both of them have been submitted to the FDA. So the common side effect we see with them is the side effect that we see commonly with all the our vaccine. So pain at the site of injection, if you have received the vaccine over, and I saw that many of us have been vaccinated, pain is probably almost everybody experienced this. You have pain, and some people have not just pain, but pain with swelling. And then you have headache, fever, fatigue, chills, muscle pain. And then some people have this severe side effect. And so this is the rate I just kind of show to give you a sense of how common these side effects are. About 78%, 60 to 78% of people had a pain at the site of injection. I would say almost everybody probably have pain. All the other side effects like fever, fatigue, headaches, they were extremely very mild. And most of them actually resolved within a period of a day or two. So just to put things in perspective, so you compare this side effect, the local pain, the redness, the swelling, the constitutional symptoms of myalgia, fatigue, headache, chills, fever. You compare them between the common vaccines that we have, the flu vaccine and the shingles. So this is the vaccine against shingles. So if you look at the side effects side by side, if you put them side by side against placebo, you can see that the COVID-19 side effect of COVID-19 is slightly worse than what you experience for the flu, and it's not as bad as what we experience with the shingles. So it's kind of in the middle of the way. So it's nothing out of the ordinary. It's not something that we have not seen before. And I'll be happy to share this slide with as many people as would want to have it at the end of this presentation. And I think the one that worries most of us are these rare side effects that we hear about in the news. Severe allergic reaction, the anaphylactic reaction, Bell's palsy, which means paralysis of the face. And then, of course, with the AstraZeneca vaccine, the transverse myelitis, which led to the study being stopped for a period of time. So during the clinical trial for the Pfizer vaccine, we really didn't see any anaphylactic reaction. Within 2 weeks, past 2 weeks of the drug the vaccine being introduced, there were 8 people over the 2 that developed anaphylactic reaction to vaccination. Initially, there were 2 in UK, and then there were 2 in the US, and there was 1 in Alaska, and I think a few more people. A total of 8 has been reported in the news so far. The second was the Bell's palsy, so where people have paralysis of the face. So there were 4 out of 4,000 people in the Pfizer vaccine, which is a rate of 0.0091%. And then in the Moderna vaccine, 3 out of 30,000 people in the Moderna vaccine, 0.09%. So this rate is not anywhere higher than what we expect for the general population. So if you follow people in the general population, people will have Bell's palsy, the rate were not anyway higher than what we expect. So it's very difficult whether this is due to the vaccine itself or whether it is just an issue, it's just something that people had. They would have had it anyway, even if they were not vaccinated. And then transverse myelitis with AstraZeneca, there were 2 cases. One happened in an individual that was given the vaccine. The other happened in the placebo individual. And after it was reviewed and reviewed again and again by different Food and Drug Administrative units of different countries, they all thought that they had nothing to do with the vaccine. It was something that would have happened anyway. And so remember we said earlier on at the beginning of this presentation that the vaccine has two components, the messenger RNA and the nanoprotein in which it is packaged. And part of the nanoprotein contains this polyethylene glycol. Both the Pfizer and the Moderna vaccine has this PEG lipid. And people think that the reaction the anaphylactic reaction we're getting is from this polyethylene glycol. There was a 2015 study that looked at reaction to PEG, the PEG. And they found that about 7% of the general population have some kind of allergy or reaction to this PEG lipid particle. But none of these reactions have been fatal so far. People recover very quickly. And that is why when you go to get this vaccine, they give it to you and they ask you to sit there to be observed for 15 minutes. Both the Pfizer and the Moderna vaccine has the PEG protein, PEG lipid. PEG has not been used for vaccine before, but it's been used for the development of other drugs and biologics. So this is a slide that really gives an overview of the stability of the various vaccines that are now in development. I would just like to take a look at these slides, just really comparing all of the vaccines, the AstraZeneca vaccine that is being produced in collaboration with Oxford University, the Moderna vaccine here in the US, the Pfizer vaccine, which is a collaboration between Pfizer, which is based here in the US, and biotech, which is based in Germany. And then, of course, the Russian vaccine, which is Sputnik 5. And so you can see that all of them are given 2 doses. The efficacy that we're seeing so far, 95% for the Moderna, 95% for Pfizer, 92% for Sputnik 5, and then the AstraZeneca is between 62 to 90%. We kind of talked about it last week. So the storage, the good thing about the AstraZeneca vaccine is that it can be stored in regular fridge temperature. The Moderna is going to require 20 degrees for up to 6 months. The Pfizer one require a very cold storage, which will be a big challenge. Russians think that their vaccine is going to be just stored in a regular fridge temperature. So this is how the WHO thinks they're going to be priced, that the AstraZeneca is probably going to be cheapest, followed by the Russian vaccine, and then the Moderna and the Pfizer vaccine. So I just take my last but one slide just to remind you that only 2 of all these vaccines that we're developing in the US are going to be messenger RNA. The others are different platforms, like I have stated in this slide. You can see the Oxford is the vector vaccine. The Russian vaccine is also a vector vaccine. The Novavax is a protein subunit. I believe the Janssen is also a protein subunit. So not every vaccine is RNA or DNA, so you have options besides the messenger RNA vaccine. And I think before the end of the first quarter of next year, you have more than just 2. We'll probably have between 4 or 5 different vaccines that are in clinical use. So this is my last slide. Myself getting the Pfizer vaccine about on last week, Saturday. I had no reaction to it. It was just my first shot. I had soreness in my arm for the first day, and after then, that was it. So you can see I got it, and I strongly encourage you. And I will stop there and turn it over to the moderators. Thank you so much for your attention.
That was good.
Thank you so much, Professor Igor Ofotokun. You are a treasure to the Association of Nigerian Physicians in the America. I want us all to remember that we have people here that are non-doctors that have joined us. So they will be invited to ask questions. Please write in the chat group if you have any questions. We will try our best to answer as many as possible. As you can see, Professor Igo has put forward a lot of answers to a lot of the questions people have, but that's not going to stop us from having questions. So please go ahead, write in the chat group. Dr. Aham, Onyike, and myself will try to catch up. Dr. Aham, Onyike will take more of the question and answer, but before that, we need to have the, we have a high place representative from the WHO, and I think Gavi here. After this talk, Dr. Aham will introduce them, and after that, we'll take questions and answers for all the panelists. I will try to concentrate on the chat group to answer questions there that are simple. I have noticed Dr. John Nadi, who is another infectious disease doctor in the ANPA community here in Louisiana. He's also a vaccine investigator at Oshna Baton Rouge. Dr. Nadi, if you can hear me, please to help me answer questions also in the chat group. Dr. Aham, Onyike, please.
Okay, thank you, Getty. So I'll piggyback off of that and say that was an excellent lecture. Clearly, Dr. Igo has demonstrated why he is a professor, he's a teacher. I think we all could appreciate that. It was a brilliant lecture, fantastic illustrations that nailed the points. And as Gertie said, he answered 10 questions, or he said he will answer 10 questions, but I believe he answered more than that. There are many other things that I had wondered myself that he addressed. So he did answer more than 10 questions, but nevertheless, as Gertie said, we all have more questions. Again, direct as much as you can to the chat. We'll answer them as they come in. Our panelists are encouraged to peek in at the chat and also answer questions. And we will, as time permits, using my discretion and Gertie's discretion, pull some of those questions from the chat to the verbal discussion.
Yeah.
Without too much delay, I also want to mention that we have, as already mentioned, representatives from both the WHO and the Gavi Foundation. To make that introduction, Dr. Hezekiah Adesanya, an ANPA stalwart, recent chair of the Philadelphia chapter, Philadelphia, Delaware chapter. He has, on his own, made efforts to bring these two special guests contribute to today's discussion. Dr. Hezekiah Adesanya, please go ahead and unmute your microphone and introduce the guest speakers. And thanks again for bringing them to us.
Thank you, Aham, and thanks everyone. Thank you, Professor Igo. Let me echo.
Dr. Adesanya is muted. Dr. Adesanya, unmute yourself, sorry. This happened because some people were making background noise. So again, we encourage everyone to help us out by muting your microphones, except the person speaking.
All right. Well, thanks, Aham, and Professor Igo, thank you so much. I wish I could sit in your classroom and listen to you all day. My question is, you should have been one of my professors back in medical school. My life would have been way much easier there. Thanks, Gertie, and thanks, ANPA President and the chairman of the ANPA Advocacy Committee, of which I'm a member. Our task is to bring about relationships where ANPA's mission, which is a healthier Nigeria in a healthier world, can be recognized. And I see other stalwarts of the ANPA advocacy group present. Last week, when we had a meeting, this same conference, a question was raised. And the question was, where is Nigeria in the vaccine world for COVID-19? What is Nigeria doing? I heard that question, and the good thing was one of my colleagues, an old school mate, back in government college, Eric Moore in Surulere, also happens to be a member of staff, a high up member of staff at WHO. So we got talking, and he introduced me to the person from Gavi. I'm not sure Chioma from Gavi is available. this is a holiday weekend for people in Europe. So if she's not present today, that's fine. So the whole premise of the presentation from WHO is to show us what is there by way of vaccines and what's available to Nigeria. And of course, the collaboration opportunities between ANPA, WHO, we can speak to Gavi issues later, which of course will be had in subsequent meetings. So without much further ado, let's welcome Mr. Debo Akitunde from World Health Organization, who will talk to us in about the next few minutes. Thank you. Debo, please.
Thank you very much. Good evening, compliments of the season, and Merry Christmas to fellow Nigerians and everyone in this forum this evening. It's my pleasure to be here today. I'm speaking from Geneva. We're actually on a forced holiday due to the COVID situation. Everywhere has been locked down, and we're waiting till Monday before we know what's going to happen. It's the first time in Switzerland that all the stores, including the airports and the stations, have been shut down just because of this pandemic, and it's never happened before. So there's a huge awareness, and we're trying to tackle it from our own side. As we all know, WHO headquarters is here in Geneva, and we're working with the Swiss national authorities and the government to see how to mitigate the current situation. So as Dr. Adefuye mentioned, we got speaking a few weeks ago, and I was quite interested in what this laudable association was doing and how could we collaborate with the association. How do we create the visibility, one, in the country, two, to collaborate with the national authority, Ministry of Health, who we work with, the Ministry of Health of Nigeria, and to see how also the support could trickle down to the community level. And this was one of the things we discussed extensively. And from our discussions, I raised up the issue of a colleague of ours also in Gavi, who is the senior advocacy manager in Gavi, who handles this there. As we are all aware, which is also in the public domain, Gavi is currently looking at avenues of how to support countries through the COVAX, and also how to ensure that countries can, who cannot afford to buy the vaccines and can have access to the vaccines. And this is one of the areas we wanted Choma to speak about, since she's also the focal point collaborating with Gavi in Geneva at the head office. Unfortunately, she couldn't make it due to family issues, and she has said she's looking forward to joining sometime in January, because she was looking forward to it in January, not in December, as this popped up. Now, coming back to where I am, I work at the World Health Organization. I've been with the World Health Organization for 2 decades now. I started my tenure working with this Stop TB partnership and the polio eradication initiative. I worked with the National Program on Immunization, NPI, in Nigeria, and I was involved in drafting the first ever public-private partnership agreement with Coca-Cola and the ICC, Intercoordinating Committee, that ensured that the vaccines could be distributed to all the 776 local government areas in Nigeria. As we all know, then Coca-Cola had the largest fleet of vehicles and in Nigeria, and we did this in collaboration with the Rotary International and colleagues from UNICEF, and also USAID and the Pathfinders Foundation and Red Cross. And we were able to ensure that the vaccines were under cold chain, which Coca-Cola supported. This was done for 3 years. And after that, I moved to the area of neglected tropical disease. So right now, I'm the focal point working from Geneva on the neglected tropical disease. This is an area involving over 20 neglected tropical diseases, which we have majority of them in Nigeria. We have been able to support most of the NTDs in Nigeria as of today. We just 2 weeks ago, we had the Minister of Health of Nigeria, who was in our webinar series on public-private partnership. And we are currently discussing on how to roll out the roadmap for 2021 to 2030, how to ensure that neglected tropical diseases, the major ones that are moving towards eradication and elimination, are sustained. For example, we're moving towards the human African trypanosomiasis, also known as sleeping sickness. We're ensuring that this will be eradicated, become a public health issue, hopefully by 2030. We're also pushing for yours. Yours is also predominant in Nigeria. We have sleeping sickness in the area in Abraka. We're supporting the Institute in Jos. And we're also pushing towards the eradication of borreliosa, which is predominantly found in the south and southwest part of Nigeria. Then we're also working on ensuring also the eradication of guinea worm. Right now, Nigeria is free from it. And of course, this is a very great achievement for the country. And there are a few countries left with it, with that now, which we're pushing towards that. We're also ensuring that onchocerciasis, which is another area that we're supporting and pushing. This is under the ESPEN collaboration, which is coordinated by our regional office in Brazzaville. Just to give you a bit of, I must commend also, Professor, for your beautiful presentation. And I was quite interested, and I liked the way you broke it down in terms of the manufacturers as of today, and what are the options available in terms of price, in terms of opportunity cost, and also accessibility. We have what you refer to as access to medicine. And as you know, we have a department in WHO that handles vaccines. Right now, we have a committee called the ERC. ERC is working towards ensuring that these vaccines are not only affordable, but also accessible to all the countries that can access them. And this is one of the things WHO is going through. So all the protocols that they have gone through right now, they are being passed through the ERC in WHO to ensure that the vaccines meet the standards, and to ensure that the protocols, the clinical trials that have been engaged are also within the guidelines that WHO has instilled and rolled out to countries. And another thing we're doing is, for example, in the NTD, we're the only departments we currently have over 11 pharmaceutical companies that are supporting the neglected tropical disease in the world, especially in Nigeria. We have the Sanofi. Sanofi single-handedly has provided drugs for human African trypanosomiasis for the past 20 years, free of charge. And this is what they use for the treatment of patients affected by the sleeping sickness, trypanosomiasis. We are also receiving donations in kind for borreliosa. We're getting donation from ERC. It's called azithromycin. Azithromycin is one of the drugs that is used for the treatment of yaws, eradication. It's been donated by a pharmaceutical company called EMS, the Brazilian company, and they are the ones that have donated these drugs for the next 5 years, and we're giving it out free of charge also to all the countries who are endemic with the diseases. We also have Pfizer donating for the treatment of river blindness. We also for trachoma. We also have for trachoma. Then we also have Johnson & Johnson. We have Merck. We have GSK. We also have General Electric. All these companies are currently donating drugs to support countries that are endemic, and those who also have non-endemic cases, imported cases, are also being supported directly through the World Health Organization. We're also ensuring that we're rolling out support to the countries in terms of training guidelines, and we're ensuring that from the NTD area, which is also collaborating now with the vaccine, COVID vaccine, because everybody now has to start thinking of how to implement the activities in the place of COVID, with the face of COVID today. So this is one of the things we're doing, and this is a priority for our DG, who has mentioned this out. So I must say that it would have been interesting for us to be able to hear from Choma, which would have given us a robust information about what is being done today from the Gavi side, and also how WHO is collaborating with them. Thank you.
Thank you so much for being here today. At this point, we're going to open the session up for questions and answers. As Dr. Akintade is going to be here to answer questions that we may have in terms of the coalition between WHO and Gavi.
Thank you, Getty. So we have an open floor now. Clearly, we have a breadth of panelists that can answer questions pertaining to the molecular biology of the vaccine itself, the clinical results, the expectations, side effects, and things like that. We have people on the pharmaceutical end that can chime in as well. We have people on the Nigeria side, WHO, Gavi. So I think we are confident that we can cover COVID-19 and vaccines both broadly and deeply. Without holding on too much longer, we'll go ahead and involve Dr. Igo. What we'll do is we'll call the panelists as the questions arise, but panelists on their own are also free to chime in on questions to add any additional perspective or vantage points. So Dr. Igo, there have been a lot of questions in the chat, and I want to immediately pull my colleague, Dr. Anyanwoke. Dr. Anyanwoke, if you I hope I didn't mispronounce your name, but you could unmute your mic and go ahead. And he had about 3 questions.
Is it Dr. Anyanwoke? Is it me?
Yes, Dr. Anyanwoke, I'm sorry.
Okay, no problem. Oh, thank you for the presentation. I kind of entered a bit late. I'm a maternal fetal medicine specialist currently in Kentucky. I just wanted to know if there was any projection, especially since we have someone from the WHO on, if there's any projections regarding the projected compliance, considering all the vaccines available are 2 doses. If is there a projection of the percent compliance that those people vaccinated will get the 2nd dose, will get the full 2 doses? The second question is, if a person gets the vaccine and then becomes symptomatic with COVID or incidental asymptomatic, what are the recommendations to continue the 2nd dose? And the third question is, if someone gets vaccinated with the 1st dose, but then forgets to go in for the 2nd dose, what's the maximum amount of time they can take the 2nd dose?
So we'll let Dr. Igo answer that, and then the WHO representative, Akintade, can chime in on the parts pertaining to your end of it. Dr. Igo.
Can you hear me?
Yes, we can.
Okay, great. If somebody is vaccinated and gets COVID, that person should be treated like any other patient. If they are symptomatic and they are severely ill, they should receive all the standard of care treatment that you normally would administer to a patient with COVID. And those standard of care, I think, is fairly well established in our healthcare institution here in the United States. So the way the body responds to vaccination, usually after the 1st dose, within about 7 to 14 days, you develop protective immunity. And so both antibody as well as T-cell response usually takes about 7 to 14 days, usually on the average, 12 days to kick in. So the 2nd dose is usually given for the mRNA vaccine within 3 to 4 weeks, 21 days to 28 days after the 1st dose. And the reason we give the 2nd dose is to enhance to boost. It's kind of more like a booster dose. So we know that the 1st dose, from the data that was provided, published from the Pfizer vaccine, after the 1st dose, people usually get about 52% protection. When you give the 2nd dose, you increase the protection to 95% efficacy. And so if you miss your 1st dose, miss your 2nd dose after the 1st dose, assuming you miss it within that 21 days to 28 days, even if it is 3 months later or 6 months later, you can go back and get a second dose. So there is what you call the memory B cells. They will still remember. There is that memory response that is there that will remember that you have seen the vaccine before. So you can go back, but we usually recommend that you go within the 21 to 28 days because you will get the maximum benefit. But if for some reason life happens and you forgot, still go back and get it whenever you can get it. Does that answer all your questions?
Yes, but specifically, if someone gets COVID after the first, I mean, it's just hypothetical. Someone gets COVID after the first dose, what do you tell the primary care team when it comes to vaccinating them? Like
for the second dose?
Yeah, for the second dose, they still should follow that 28-day or whatever day schedule based on the vaccine.
Yeah, so this is a very interesting question, and I don't think we have the data to answer that question, but what I can speculate based on our knowledge of how the body responds. So the first dose, you get response, and then you get a natural infection. The likelihood is that that natural infection is almost like a booster. You know, you're going to be exposed again to the spike infection. And from the data we're seeing so far, people who get infection, even the second infection after the infection after the first dose, most of those infections tend to be mild. What will I do if I have my first dose on Saturday? If between my second dose in 3 weeks' time, I get infected, will I go back for the second dose of the vaccine? I will, because I will just want that extra boost. But is there data to support that? No. My suspicion is that the fact that if you got an infection in between the doses, that infection itself serves as a booster to your original vaccination. But I will go ahead and get the second vaccination as recommended just to complete the series.
You know, in addition to what he just said, you know, part of the recommendation really is that even for individuals who have been infected, who have recovered, that you should still go ahead and you should still go ahead and be vaccinated. And it's just that you wait, you know, you wait for 90 days before you go and take your vaccination. And just like you said, you know, that your second dose is actually your booster. So, you know, so if you actually end up with infection, you know, if you actually wait for a period of time, if it's actually in a place where, you know, they actually can measure, you know, your antibody response, that probably would, if anybody is able to do that. But in most places, it's not, that's not going to be a viable option. And, you know, after the period of 90 days, I will still go back and still get the vaccination, because it only enhances, because the thing is, when you get the first dose, you know, even if you actually get a robust response, how sustained it is, you know, is it going to be if you don't get the second dose?
Okay, thank you, Deji. So we've gotten into the nuances of this discussion, infection in between doses. Very good point by Dr. Igo, that the second dose, even though the recommendation is 28 days, can be as late as 6 months and still be effective, even though it's best to follow the recommendations. I'll throw the next question, which I'm pulling from the chat, at Dr. Nnedu, Obi Nnedu, our speaker from last week. You can go ahead and unmute your mic. A recurring question, but for those who were not here last week and perhaps who were not satisfied with your response last week, what are the long-term concerns with the current Pfizer and Moderna vaccines? Dr. Nnedu, please.
Yeah, thank you very much. That's a really, really good question. I think it's a two-part question. I think one is, how long will the vaccine work? And, you know, we don't know that for sure just yet. Individuals who were enrolled in the clinical trials will be followed for 2 years. And so we'll have 2-year data. And then the thing with vaccines is, even after they are approved by the FDA, there is still a post follow-up, in other words. And so
Cases of individuals who were vaccinated who still get COVID will be reported, will be monitored, will be recorded. And so we'll have even more information in terms of how long these vaccines are going to work. The data that's been presented was basically data where these individuals were followed for up to 2 weeks after the second dose of vaccine. And essentially in short-term follow-up, it appears to be extremely effective. Then the next part of the question is, will there be any long-term side effects related to the vaccine? I'll answer this by doing a little bit of extrapolation. So one, with the mRNA vaccine, when it's inoculated into someone, it produces this protein. The protein is presented on the cell. The actual mRNA goes away. It doesn't last. The cell, it pretty much gets destroyed and it goes away. Then the body mounts an immune response to the cells that have this protein on its surface. Those cells go away because the immune response destroys it. And then you ultimately have the memory that Dr. Igor was talking about, that is the immune memory. And so what you're left with is immune memory. You're not left with mRNA lingering in your body anymore. And you're not left with the protein lingering in your body anymore. Instead, you have immune memory that should the body encounter this protein again, the immune memory immediately picks up and takes care of it. We have vaccines that essentially do similar things that lead to immune memory. And what we know from these other vaccines is the likelihood, basically in the history of vaccines, side effects beyond about 6 weeks of actually getting the vaccine are virtually unheard of. And so the likelihood of there being any side effects from a vaccine you got this year, happening 1 year, 2 years in the future would be extremely unlikely. We haven't encountered that before in history. And so it will be unlikely for that to be the case with these two vaccines.
Okay, thanks for the response. So the evidence seems to indicate that there really shouldn't be any major concerns, but we need more time. As with everything else COVID related, it's obviously new and we still need more time. Dr. Anyanwoke will call on a few people from the chat who've raised their hands.
Thank you, Dr. Onyike. I would like to call on Dr. Adedeji Adefuye. She is one of the directors at the Federal Ministry of Health in Nigeria. She has a question to ask, and I will quickly piggyback on it because I see that there is also a question for her by Dr. Abraham Oshimbowale. Dr. Abraham Oshimbowale's question to Dr. Adefuye is, how prepared is Nigeria for the administration of the available vaccines? And how prepared is the government to mitigate the issue of resistance to immunization, considering the same problem we are noticing here in the United States of America among people of color? So, Dr. Adefuye, you have the opportunity to ask your question and also answer Dr. Oshimbowale's question. Thank you.
Yeah, thank you very much. First of all, let me thank Dr. Jetty and the whole ESCO of ANPA for inviting me to this conversation. And we never can learn too much about COVID-19 because it's quite new to everyone. I would say that Dr. Is it Ogunbowale question is actually resonating with the question that I was asking, that we really need to fight vaccine resistance, and the government of Nigeria is making concerted efforts to ensure that this is tackled headlong. The Honorable Minister has set up a task team, not task force this time, task team, technical, and will be advising government, particularly on the type of vaccine that we should go for, the one that will give us a cost benefit, and then and also the task team is advising on risk communication and sensitizing the Nigerian public. A lot is already in the on the airwaves, the print media, trying to educate the Nigerian public. We are going through even the gatekeepers, the traditional rulers, the religious leaders, to ensure that they first of all make the public know that COVID-19 is not a fad. It is real, and government is encouraging the VIPs, the public figures in the society that have contracted the infection and have survived it, to come and tell their story, and thereby those are the ones that are even encouraging, sending encouraging messages to the public to make them to believe that there's COVID-19, and then when the vaccines come, they should take it. And with the examples that we are seeing with the public figures in other climes taking it, of course, that is being aired to the Nigerian public to make sure to encourage them to take it as soon as it gets to Nigeria. But my own question really is, which of the vaccines is advisable to us? Of course, we want to look at when we want to look at the cost, we will want to go for the cheapest. But on the long run, which one is advisable for us? One. Then number two, when should we be expecting? I believe this question will go to Gavi and WHO. But when should we be expecting all of the vaccines that will give Nigeria the herd immunity? The Honorable Minister, from the discussions that are ongoing with WHO, we are expecting something, the first batch in the first quarter of 2021. But should we be lagging behind the most populous country in Africa? Should we be behind other countries? And we know the inflow of people from the Americas, from Europe, that will constantly be importing the virus to Nigeria. So we really want to get the herd immunity as quickly as possible. Thank you.
You know, if you guys will allow me to take this.
Hello.
There's so many questions, you know, that you raised. First and foremost, you also made some comments, and you know, I am really constrained to answer to, you know, respond to some of those things. Some of the questions that you're asking us are some of the questions that we really should be asking you. This is not the time in Nigeria that we should be putting, you know, we should be saying, you know, having a committee or a task force to advise. This is a time that we should actually have a committee that actually is acting and implementing. I am sorry to say that we're coming rather late to the dance. We're still negotiating when some lowly African countries have already made down payments to secure vaccines. We're still talking of how we're going to get vaccines. So, you know, we need to up our game. We need to do better than what we did. That is what the bottom line, or what, you know, for those of us in the Infectious Disease Committee, you know, both Getty, Obi, and Igor, we discussed several times about the main concerns that we had was really vaccine procurement. And I don't think we've done a very good job of vaccine procurement. So, we're among ourselves and we should speak the truth here. That said, if you're talking about the vaccine, you already seen what Dr. Igbo actually presented in terms of the type of vaccines. And by mRNA vaccines, by their nature, are very fragile. They don't last too long. And that's the reason they are destroyed quickly in the body. And, when you can't keep them at those temperatures, it's going to be difficult knowing that, they actually get denatured, with temperature excursions. So, it's a question of VISA has actually provided, transport, and storage, materials to be able to keep them at those temperatures. And of course, the AstraZeneca one is one that actually might be easier, to be able to distribute or use in Nigeria, but that's not approved, and we don't have to wait until that's approved before we get moving. So I believe, just like we advise other people, it's just whichever one is actually readily available is one that we need to get our hands on right now. And then, we actually also can tackle all the logistics that are necessary, that are needed to ensure those vaccines, maintain their efficacy and potency, through storage and through storage and transportation.
All right, Dr. Deji, let me also make some comments. Thanks for your observations. Actually, unfortunate that the Gavi person could not make it, because she would have presented to us the full slew of other vaccine choices that are available for Nigeria. Nigeria has also been designated as part of a low-income countries group. And all those countries, whether in Africa or Asia, they acquire vaccines through the COVAX platform, in which there is some, there's an algorithm, adjustable algorithm in terms of the pay down payment of maybe 10 to 20%, or if they can afford it, 50%. And then the vaccines are given to them. The whole point is to make sure that it's given out for free. So I guess this is where the promise of ANPA, working along with WHO, Gavi, Ministry of Health, task force or task teams, just to lend our voices into the process as we look at what's happening within that population, to make sure that this thing goes out. It goes out free, as has been promised. Actually, Gavi is looking at us helping in that environment. So this will be discussions at a later date. So just wanted to share that information. Thank you.
Yeah, it's important. What COVAX is actually doing, as you probably know, this is actually, this is my day job. Not only just, manufacturing pharmaceutical products, ensuring they're efficacious and safe, but also ensuring that, populations that need them actually get them. We actually have a special program that they call Access to Medicines. COVAX actually works with Access to Medicines. This is what really happens is that COVAX actually submit tenders, and that's the reason that, the vaccine is not going to be sold at the same price in Nigeria and India or Gambia, for example, with the same price that is actually being sold here, in the US, or the pharmaceutical company are selling it to the US government because nobody is paying for it. What actually happens is that COVAX actually submit tenders to all the different, companies, and actually get all these products, through specialized programs that provide them at almost, next to nothing. And that's how COVAX is actually able to ensure, that, all these different countries actually get this. So if we're actually able to get somebody from COVAX or somebody from Gavi can actually tell us exactly where those tenders are. And, it's not just the tenders, but how much of each of these different vaccines are actually coming from, from the pharmaceutical companies, because the pharmaceutical companies by nature always designate a proportion of their products to programs like this. they're in the business of making money. So if they have 10 million doses, I don't know how many of those 10 million doses they're going to devote to a program, which is not really making them money. So we need to be very cognizant of this. And Nigeria also needs to be very cognizant of this. The reason I'm making this, I'm actually saying this, is that we should not be 100% totally reliant on COVAX and Gavi for getting this. We, as a country with the amounts of money that we have and we fritter away, on a daily basis, we should be able to put money forward to be able to, outside of COVAX and Gavi, to be able to supplement what we're going to be able to get from them. Because remember now, we are not the only country that will be going to Gavi and COVAX. There's a lot of other countries that are much, much poorer that actually will get preference when it comes to distribution, who are also approaching the same agency.
Very good, sir. Sorry to take out some oxygen again. I mean, and you're quite right that Nigeria should step up to the game to look outside Gavi/COVAX platform. Unfortunately, Mr. Adedeji had to leave. One of the programs that WHO also runs, where grants are available also for countries like Nigeria, working strictly through NGOs
listening to something
that can also help to supplement those programs in Nigeria. Actually, Dr. Bamigboye,
I don't even know what time it is.
Dr. Bamigboye, Advocacy Committee, I see you made a comment. If you'd like to just say what you just said in the chat group. Thank you.
Yeah, thank you, Dr. Adefuye. Dr. Sani Aliu, who I believe is part of the Presidential Task Force in Nigeria, actually made a comment on BBC that Nigeria will be getting almost 40 million doses from WHO, and it will be free, according to him. Dr. Sani Aliu has a brother here in Nashville, so that's how we were able to get that information. So I think I do hear, and I know that, some people say, Nigeria needs to be at the table during this discussion. We can't just be starting to plan. Somebody said, if you are not at the table for dinner, you'll be part of the menu. So.
May
Thanks, Dr. Bamigboye.
I quickly?
Yes, madam. Dr. Adefuye, you have the floor.
Thank you very much. I was just being careful in giving the figures. I'm aware that Nigeria is already at the table, particularly with COVAX. And you recall I mentioned that we are expecting some doses in the first quarter. I know that 10 to 20% of the vaccines, as has been promised to WHO and through COVAX, we are expecting about 10% of the Nigerian population, which is about 20 million in the first tranche. And going forward, we are also making arrangements for other sources, so that we can begin to increase the population of the number of people in the country that will get the vaccines. What I was trying to get from this meeting, or from the panelists or the participants, is there any arrangement? Is there any other advice that we can get through your platform to support Nigeria and facilitate more doses coming to Nigeria? That was what I was trying to get from my question. But to say that Nigeria is at the table, yes, Nigeria is already at the table, and the task team that was set up is not just to to begin to advise Nigeria on what we are going to be doing, but to study the whole vaccine environment and even the dynamics of the COVID infection, and advise government on maybe policy formulation, and even when we need to review policies. And Dr. Sani Aliu, that was mentioned, is the national coordinator for COVID-19 Presidential Task Force. Thank you.
Okay.
Thank you, Dr. Adefuye. I will quickly ask two questions from some members that have typed their questions. There was two of them, or a couple of them were on immunogenicity and immunoprotection from the vaccine and when to revaccinate. And there was another question by Dr. Ogechi Nwiwu. Dr. Nwiwu, are you still here to ask your question? Because I think we could couple those two together.
Yes, I'm here.
Please ask your question.
Okay, my question is, some of my patients, when they come in, they ask me how about the vaccine, the long-term side effects, like how sure am I that in the next 5-7 years, there's not gonna be like an adverse side effect from the vaccine on the population? Could you please help me with the answer to give them on that?
Dr. Nedum had answered that earlier, but I'll let him go ahead and recap his previous answer. Dr. Nedum.
Yeah, so that my answer was that it will be very unlikely, knowing what we know about how vaccines work, how this vaccine works, and how vaccines in the past have worked. In the history of vaccines, generally there hasn't been any side effect beyond 6 weeks after getting the vaccine. The way this vaccine works, as was alluded to by Dr. Ego earlier, the mRNA is inoculated. It produces the protein is presented on the cells. The mRNA itself goes away, so it doesn't stay in the body. There's an immune response to the protein that's presented on the human cells, and then those cells go away too. So the protein itself, it doesn't stay either. What stays is the immune memory, and that's what gives us long-term protection. Now, obviously the people who got the vaccine will be followed for 2 years to confirm that there's no late side effects, but based on what we know about the immunology of vaccines and how this vaccine works, I would say, if I were to offer a professional opinion, that it would be highly unlikely for there to be any side effects 5 years down the line related to.
Okay, thank you. So I'm sorry, Gertrude. There are a lot of questions, a lot of interest. The appetite is strong. I think we still have a lot of time, so we can get to everybody's questions. If you will permit me, maybe you can flush out the questions coming from Nigeria and then we can move on to maybe back to a bunch of the broad clinical questions that remain unanswered. Dr. Debimpe has made it clear that Nigeria is on the table. There's an internal process to advise government on the best way forward pertaining to the vaccine for Nigeria. There is a commitment from the WHO for 40 million doses, which, considering it's 2 doses per person, will cover 20 million people. And that's going to be free, that the Nigerian government can expect. And the issue is, what do we do beyond that? That also raises the question, do we have a Nigeria-centric solution to the pandemic? 20 million doses, especially if it only lasts for a few months, is that enough? Is that a wise decision? Are we receiving the cheapest vaccine? And if so, has it been tested? Are we as confident in it as the other options that may have had the scrutiny? So to touch on some of this, Dr. Ofotokun, can you advise that a plethora of vaccine options for Nigeria? Do we have confidence that we will make a choice in a vaccine that we recommend to millions of Nigerians that is as safe as what Americans and people in Europe are getting? And if so, what is that vaccine?
I just wanted to share my slide here. Let me see here if I can go to these options of vaccines. Can you all see my slide again?
Yeah.
You need to make it bigger.
Oh, I need to make it bigger. I see what the problem is. I'm using my larger screen. Is that better?
I think you need to go to the slideshow.
Okay, let me redo it again. Let me give this back to you. Let's see here. Is that better?
Yeah,
this is better.
Okay. So these are the so this is not peer review slide. This is from the WHO and it was published by BBC. So almost every government, Nigerian included, will be making two decisions. How cost effective is it? And then two, the cold chain. How durable, what is the shelf life of the product? Those are the two major things. Of course, the big question is effectiveness. My sense is that all of them are products that are directed against the spike protein. My sense is that the efficacy is going to be comparable. I know when you look at this slide, you see 62 to 90%. At the end of the day, I have a feeling that the efficacy is going to be comparable across the board. When we started this journey in March of this year to develop a vaccine, actually started in January, we were hoping for a vaccine that would be 60 to 70% effective. So that we have 95% is above and beyond what we were expecting. You know, by every standard, a vaccine that gives you 60 to 70% effectiveness is a good vaccine by any standard. And so if you look at, I think it's the cold chain and the cost that is going to drive the cost, not just for Nigeria, even for rich countries. They don't want to waste money. And so I mean, what we're beginning to see is that those vector viral vaccine, they have a better shelf half-life, so you can keep them in regular refrigerated temperature, and which is what we see with the Oxford AstraZeneca vaccine and also the Sputnik vaccine. They can be kept in the regular, it doesn't require cold chain. And I think the other advantage, there are products that are coming in. The Johnson & Johnson vaccine is also a protein subunit and is given only once. It's not 2 doses. So that is another consideration that is going to be taken, that people are going to take into effect. Not just the cost of purchasing the vaccine, but also the cost and the resources that is required to give the vaccination itself. So it's probably going to be more cost effective to give a vaccine that is given just once than to give vaccination that is given twice. So countries are going to have a lot of options. And I have a feeling that by March of next year, a lot of these studies will be completed and there's going to be a lot of options. The other thing that is going to happen is that because we have so many options, so it's just kind of this economy, what is it now? The market forces. The prices are also going to be driven down because it's not just these ones. The Chinese are also producing, they're also trying their vaccine. And I think the Indians also are in the process of developing their own vaccine. So there's going to be a lot of things that policymakers in the resource limited setting as well as a resource rich setting are going to sit down and decide what is the most cost-effective vaccine in terms of efficacy, in terms of shelf life, in terms of the number of vaccination that is given to achieve the desired results. So those are decisions that Nigeria and other countries across the world will be making. The point I just want to leave us with is that all the vaccines are going to show probably at the end of the day, they are going to be equally effective.
And would you say equally safe?
So the safety would depend on, so remember, it's not just the vaccine itself, the antigen that is in the vaccine, but what they call the emollient, so the other part of the vaccine. Like we said, in the case of the mRNA vaccine, you have the lipid nanoparticle, which we think people are reacting to. And so we would see when the studies are all done, the safety data is going to be available and countries are going to be able to make informed decision.
Okay, so what would like to get will be some additional opinions on what you recommend for Nigeria. And we can let Dr. Adebimpe as well as the other panelists chime in. Currently, the total number of infections reported in Nigeria is around 75,000 people, and correct me if I'm wrong. In spite of 9 months of the pandemic, we know there's significant underreporting, but if we look at a denominator that's harder to hide, which is mortality, Nigeria has about 1,200 plus people, very small for comparisons to Europe and the rest of the world. And that's been experienced in sub-Saharan Africa. So if we're looking for herd immunity at 70% with vaccine programs that we don't have guarantees we can afford or we can get our hands on, could we somehow already be at herd immunity considering the low mortality that we're seeing in Nigeria? And if so, do we really need to invest heavily in vaccines? Dr. Igo, Dr. Nnedu, and Dr. Adebimpe, Deji can chime in as well. Is Nigeria, considering the low mortality, should Nigeria really invest in vaccines if we're going to achieve roughly the same with 70% herd immunity to what we're already seeing?
I think you raised maybe Dr. Adebimpe should go first, and maybe at least given the Nigerian experience, and then maybe we can chime in. So go ahead, please.
Okay, thank you very much. I think I will look at it from the perspective of what we are already doing in Nigeria. There's already a survey going on, and this is focusing on testing the antibodies already in the population, and with this we will have an idea of the number of people that are already that already have immunity for the virus. And then we are also looking at ensuring that when the first batch of vaccines that arrive, we actually go to the vulnerable people, the frontline health workers, the most exposed persons and the vulnerable. And we're expecting that as time goes on, the population will continue to build immunity and will be moving towards the herd immunity. However, the task team are expected to, one of their terms of reference is for them to continue to monitor the dynamics of the COVID-19 itself, not just the vaccine now, but the dynamics in its entirety, and advise government. And when it comes to the choice of the vaccine, they will be able to tell the government, notwithstanding the some investment that might have been made, if we need to do a detour and it will save Nigeria unnecessary expenditure, why not? That is where we are really. Thank you.
Yeah. Okay. Thank you so much. Thank you, Dr. Ade. I just wanted to say one thing about COVID and why we need to vaccinate. So remember, the mortality rate is very low. It's depending on how you look at it, it's anywhere from 1 to 2 or 3% at the most. But the severity of illness is not as low. About 20% of people who have the disease have severe illness. And what we're beginning to find out is that not only do they have severe illness, they have long-term sequelae. We don't really know the implication of that long-term sequelae yet. Many of them have cardiac issue. Some of them have pulmonary issue. Some of them have hematologic issue. Some of them even have neurologic complications. And so I think it's going to still, if you look at long-term, it's going to be cost effective to prevent infection than to deal with the consequences of natural infection and the cytokine storm that it causes. Even if people survive, the sequelae of COVID vaccine leaves people permanently maimed, and we don't know the impact of that. We don't even know the full impact of the long-term complication of surviving COVID vaccine just yet. I still would recommend that it would still be cost effective to vaccinate against natural infection.
You know, I am totally in support of that. And, you know, a lot of the vaccine preventable diseases that we vaccinate against, it's not because they all, you know, those diseases actually cause mortality. It's part of the morbidity that it causes, the long-term sequelae that you actually have, you know, over a long period of time. We're still learning every day, you know, about COVID. And we're seeing a whole bunch of different symptoms. You know, Dr. Ego already mentioned a lot of them. There are also neuropsychiatric symptoms. I've had individuals who tell me they have all kind of different nightmares, wake up in the middle of the night, they can't sleep, all these different things. And, you know, one life saved by a vaccine, you know, it means a lot, because when you actually consider the fact that that person, if that person is a family or friend and you're saving their life, even if it's just a few that you actually save. And, you know, I'm actually pleased to hear what Dr. Adefuye mentioned, that they're now trying to do some testing in Nigeria. I'm sure Getty probably is nodding her head because it was just a few days that we were talking about a proposal on how to do sentinel surveillance in Nigeria, because we know there is gross underreporting. And the only way that we will be able to at least do an estimate of the level of infection in Nigeria is to be able to do more like, you know, a sentinel surveillance in which individuals at, you know, certain hospitals, you know, across the country will be randomly tested to find out if they actually have, you know, COVID antibodies, that kind of thing. So if you're already doing that, I think that actually will be very helpful. It will be able to give, you know, a better picture of the incidence of COVID-19 in Nigeria. And, you know, when you complete this, you will see that what we currently report, given that a lot of the diseases in Nigeria have almost very similar symptoms, that you really will not be able to, you know, to really be able to differentiate. So if you're doing this, I think it's great. You know, the vaccines, I'm sure that it's, you know, we can provide advice and all that. I think it's really what you have on the ground in Nigeria in terms of logistics to be able to, you know, help not just the distribution, but vaccination. That's going to determine, and I'm sure that the task force that the governor has put together, you know, will evaluate all these different options in terms, you know, of the one that is actually most cost effective. And I would just mention, you know, before I stop that, if you need any assistance in being able to navigate, you know, companies, I am very closely aligned with Moderna. My company is actually helping in manufacturing some of those vaccines for Moderna, and the head of clinical development for Moderna is actually, you know, an ex-colleague who actually left my current company to go to Moderna, you know, for this purpose alone. So we still talk regularly. And if there is any connection that I can make in that, I'm more than happy to.
Thank you, Dr. Deji. So I think we'll start wrapping up pertaining to Nigeria, and interesting recommendations from both Dr. Ego and Dr. Deji that vaccination is the way out, the way forward. although Dr. Adedeji just threw in a caveat that he does have a business that can support the vaccine logistics and recommendations and whatnot. But it's clear that Nigeria will need a nuanced approach. And very happy to hear from Dr. Adedeji that there is a process in place to make a recommendation, which could include a detour, as she described, if that's what it calls for. So we would look forward to being a part of that. Obviously, ANPA has the expertise to be on the table and provide advice. And we look forward to collaborative discussions like that towards Nigeria. Dr. Getty can now call on any of the questions that she deems fit from our participants in the chat. Dr. Anyanwoke, go ahead.
Thank you so much. And at the risk of going longer than we intended to, just like last week, I mean, the energy is still strong. The panelists don't seem to be complaining, so I'm going to pimp you guys a little bit more. There are two people that have had their hands raised and questions to be asked. One is Pastor Damian Luke, and the other is Ms. Rufina Umozolu. So if you each, one after the other, ask your questions, the panelists will take those two questions at once. Thank you.
Thank you, Getty. I'm actually logging in from London, and it's quite interesting to see the lineup of Nigerian professionals who are really helping. I am a pastor, and I'm appalled at the level of misinformation that my colleagues are pumping out there, especially with regard to the lack of understanding of what the Professor Eo mentioned about the nanoparticle, which has become for a lot of them a kind of a myth about Bill Gates and his introduction of whatever myth that our people are carrying. I'm concerned because your good work is being dwarfed somehow by these misconceptions. And I was just wondering if there was any value in you trying to directly take on that misinformation head on, knowing that at the end of the day, some of these, my colleagues, may have access to proper treatment abroad, but the poor members of our congregations are left to wander in ignorance. That's my approach. Thank you so much for the opportunity, Getty.
Okay, thank you, Pastor. Ms. Rufina Umozolu, please. Is she still here? I know her hands have been up for a while. Okay, I think the panelists—
Sorry, I need to unmute myself. I was talking, but I forgot that I had to unmute myself. So I really want to thank Dr. Ego, the first speaker, I think he was. He really answered a lot of my questions, and he put my heart at ease. But I mean, I have one more question to ask, and it is about that what's it called? Johnson & Johnson vaccine, because a lot of my workers, they are leaning towards that, taking that because of the fact it is like a single dose, and also and also I think it is made the same way that the other vaccines were taking now are made. And so, and my question is, what do I tell them since they don't want to take this Moderna vaccine? I had only 20 people that signed up to take it, and I have a staff of about 300 people. And so I have been trying to talk and convince them, but they really don't want to take it. They are all waiting for the Johnson & Johnson vaccine to like come out. And so I was just asking to see if there was anything I could tell them that can make them take it and not wait for the next one to come out.
Thank you, Ms. Rufina. The question is now to the panelists.
Yeah, I just wanted to say a few things. The first question was with regards to misinformation. And I think the only way to respond to that is to counter that with correct information, with information that we know from the data, but distilled in a way that people can understand it. I think it's best done on a larger scale, like what ANPA is doing now, with you know, sort of a lot of people listening in. As a physician seeing patients, when the question comes to me, I try to not dismiss the concerns. I think there are a lot of reasons why particularly Black people like us have suspicions around these things, and it's always important to understand it, respect it, but also give correct information. And that's sort of been my general approach to that. But I think more forums like this are definitely needed, and I applaud ANPA for organizing this. The second question, so the Johnson & Johnson is working with Janssen in terms of its vaccine. It is a viral vector, and so it is similar to platforms that we've used before, and it is a single dose. We don't have any preliminary data on that yet, and so I would just say it's a little tricky waiting on something that we don't have data on, where we do have some data on the existing Pfizer and Moderna vaccines, which are mRNA vaccines. And I think from my standpoint, understanding the concern, it sounds like the concern is that these are new platforms. And as Dr. Ego said, the technology has been there for a while. And we do have early safety data on these two early platforms. And hopefully Dr. Ego's talk has been able to answer some of the concerns that the person asking the questions had.
Thank you so much.
Getty, just one question, just to add to that. So the Janssen study just finished enrolling. So we're going to have the data hopefully very soon. And we would also are going to know whether it's as effective and as safe. And it will be, hopefully if it's as effective and we expect it to be, and as safe, we expect it to be also, then it will be available soon. So by the time the vaccine, everybody, entire general population is ready to be vaccinated, I have a feeling that the Janssen's vaccine will be available. And I think that is the beauty of having options. So if people aren't comfortable with RNA vaccine platform, the Janssen vaccine will be available, they can go for it. The AstraZeneca vaccine is going to be available, they can go for it. So there are options, and I think it's, for me, it's okay. If people don't want mRNA vaccine because they are concerned about it, there will be other options, and I think it's okay if people decide whatever they want to be vaccinated with. I think that is okay. And so for your employee who are refusing to have vaccination now, well, the vaccine is not available to everybody yet. But my sense is that by the time it will be available, those other options will still be, will become widely available, and people should choose whatever they want to be vaccinated with.
Okay.
You know, if I want to add to that, you know, definitely if any of your workers are those who are actually at this risk of, you know, contracting COVID, my advice to them is that they actually take the vaccine that is available right now.
I agree with that too.
If they are concerned about the mRNA platform, they need to understand that this is not new. This same technology, mRNA technology, actually has been used for producing, you know, gene therapies that people actually take. They have actually been used in producing medicines that are used for what they call immuno-oncology, that is used for treat some form of cancer. So this is not a new platform. It is only that this is the first time it is being used to develop vaccines. So they need to understand that. So it's not something that just came out of the moon, that nobody has ever used before. So it's important that they actually have that understanding. And for Pastor Luke, I really, really applaud you, and for coming and for the comments that you made. I think I hope that Dr. Adefuye is actually still online. With all the things happening in Nigeria with misinformation and everything, we have all these, we have Dagomo and all these other agencies that actually have been doing mass education in Nigeria, over COVID-19. They actually need to add, the nuance of these new vaccines, how this vaccine actually work to the public education that they've been doing, because as many people as we're actually able to educate, I am hoping that, once somebody knows, we'll talk to somebody and talk to somebody, trust me, all the members of this panel talk to people in Nigeria all the time. We get all kind of different questions and everything. Getty has made several videos on COVID-19, understanding COVID-19 and all these different things. All those videos are actually still available to people in Nigeria. That's all that we really can do. But the government really needs to be, the government, the public-private, collaboration that was actually instituted at the beginning, of this pandemic in Nigeria, just need to add this to what they've been doing. And I think they've done a fairly good job. It's only that, pastors, leaders of trust in society who keep peddling all these conspiracies, I just don't know what you really can do about them.
Maybe there's an app for that. But
Thank you.
Yeah, clearly in the ANPA community, we need to figure out platforms to be able to reach the larger Nigerian community in Nigeria and in the diaspora. So I think we'll all put heads together, and perhaps in collaboration with pastors like Pastor Luke, Rofina, with your employees, and many others out there. It's a challenge for us in ANPA to step to the plate and be that resource that is obviously needed. Getty, back to you.
Thank you so much. Dr. Adefuye, did you want to say something?
Yes, please. Thank you very much. I don't think I'm seeing anything that is too different from what is happening in other climes as per vaccine resistance. It is not unexpected. However, in Nigeria, as you know, we have a history with vaccines, and we already have the platform. We already have the gateways. We already have the framework for vaccination. We are coming from an era of even immunization coverage of less than 30% that has risen above 70% right now. And a lot of work was put into this. When you talk about religious leaders and all of that, we have we have the platform through which they are reached. And if you listen to news from Nigeria of recent, you will see governors coming out to speak out to say they have been infected. If it were before, there was a lot of stigmatization around things like this, but that is no more. We are like family planning. I was the head of Department of Family Planning for almost 4 years, and I know a lot of work was done to ensure that we remove all the so-called nuances around family planning. Now, the religious leaders, especially from the Muslim North, they speak about family planning openly. So it is the same platform that we are using to ensure that this vaccination actually all the resistance, all the negative publicity is addressed. Thank you.
Thank you, Ma. Thank you. I'm so sorry we have run again rough shoulder over the time. I see Dr. Foluade's hands up. If you will speak for just 15 seconds, I'll let you.
Okay, thank you very much. Dr. Adefuye is my name. I just wanted to ask the presenter, one of the challenges I face, I do clinical development, and there's a question that's been coming up. When patients get vaccinated for COVID, can we enroll them in active clinical trials? Because that's one of the challenges we have. Most often than not, part of the criteria for enrollment is we don't allow live vaccinated patients to be enrolled in the study, but COVID does not fall into that category. Are we allowed to allow them to be included in clinical trials, or do we need to exclude them?
I think the answer would go to the protocol team of that study. So each study have a protocol team that interprets the protocol if it is not so clear. And I'm sure that the answer to those questions will vary from the study to study, or the clinical trial, from one clinical trial to another. So that would be a question I would send to the protocol team. If it's a pharmaceutical sponsored trial, write to the CRO or the protocol team and ask them whether people who have been vaccinated, can they be enrolled?
Okay, so thank you, but I'm the clinical trial developer. I'm the protocol person. So I'm trying to understand how this COVID vaccine plays into our studies from a pharmaceutical end is the question.
Yeah. Okay, I can help you here.
Dr. Digi, thank you, because I'm getting this question every time.
Okay, I can help you. The bottom line here is that when you're writing your protocol, you have your inclusion and exclusion criteria, right? Mm-hmm. In your exclusion criteria, there are certain things that you actually put there. There have been guidances, I don't know whether you actually are aware of this, there have been guidances that actually have come out of both the FDA and also the EMA on conduct of clinical trials in the COVID era. Most of it actually covers individuals who have actually been infected with COVID-19. There hasn't been one that's come out once the vaccines become available. But
that's the problem.
But I'm actually going to look at them in the same way. That number one, anyone that's actually been infected with COVID, you're not going to enroll them in any of your studies until 90 days after they have been completely symptom-free.
Correct.
If that helps you in any way. So I will expect that, I'm expecting that there were going to be some guidelines that actually, will come out very soon as it relates to, COVID vaccinations. There isn't one, but I'm sure that there's going to be one coming out very soon. But I can actually speculate that it is going to be almost the same standard that it's probably going to require that you have to wait for at least 90 days post last dose of COVID vaccine before you'll be able to enroll. That's probably what my position will be. But, just like, Dr. Fotokun said, you also have to look at what study are you actually enrolling individuals in. Is it an is it a metabolic, program or something? You have to also evaluate that, because that, even for general things like you're looking for individuals who have had some hepatic derangement in terms of enrolling them into a clinical trial. If it's a clinical trial in which you do believe that, you know, the article of study can be hepatotoxic, you don't use the same standard you use for all other studies that the, you know, the test article is not hepatotoxic. So you might say anybody who's had any kind of liver disease or liver disease dysfunction will not be enrolled. For others, you will say probably maybe 3 times, you know, level of normal preclude. So it's going to be your call. But you know, if it was me, what I said is what I would probably suggest to you, and then you now with them on a study by study basis.
Very good. Thank you very much.
Thank you, thank you, thank you all. We've gone longer.
Way over?
I think it's like almost 30 minutes. I think we're going to stop right here. We do have another vaccine talk conference for January 16th. If there is need to do one before that day, we will communicate. But for now, it's Saturday, January 16th, same time, we're going to have this conference. You will be getting communications from myself and the team. I would like to call on Dr. Jide Bamiboye of the COVID-19 Task Force to give us a vote of thanks. Thank you, thank you, thank you all. Dr. Bamiboye.
Thank you, Dr. Gertrude Anyanwoke. Very excellent presentation and excellent conference today. It's tough to have people come in and listen to this kind of talk the day after Christmas, but it's so important that we're all here. So I want to thank first the ANPA president, that's Dr. Chris Okunsiri, for his leadership and align us to kind of do this kind of you know, educational endeavor. ANPA executive for, you know, their support, the president-elect, the treasurer, and also the past president. So the ANPA secretariat, especially Ms. Letitia Dodge, what can we do without you? Thank you so much for helping us organize this, this Zoom. And I want to thank the erudite panelists, Professor Ofotokun, the erudite professor of medicine and infectious disease expert, Emory University. Thank you so much for breaking down this very difficult topic and, you know, demystifying all the things going on out there that we've been hearing. And Dr. Adedeji Adefuye, Dr. Obi Nnedu, thank you for, you know, helping us out with your comments and discussions. I want to thank Dr. Onyike, Onyike, very superb moderator. Thank you for what you do. We had a wonderful day. I know, Getty, you don't want me to talk about you, but I will. She is of tireless energy. I mean, she is so bubbly and very, very a big educator. He has a lot of, she has a lot of video out there. So if you just get hold of her video, I mean, you are set with this COVID-19 thing. So thank you so much, Gary. You are the chair of the ANPA COVID-19 Task Force, the chair of Louisiana ANPA. I mean, you're chair of many. You have many hats. Thank you. And I also want to thank, you know, the ANPA infectious disease specialists and the COVID-19 task force members for, you know, laying the groundwork for this educational conference. And there's so many people to thank. I want to thank the Director and Head Department of Hospital Services, Federal Minister of Health, Dr. Adedeji Adefuye, for attending this Zoom conference. Thank you so much. And I don't know if there's anyone from the Agomo Foundation, but if they are, thank you to you. Ambassador Hippo Wachuku, thank you for coming. The Gavi, you know, WHO, Dr. Akintude, I think represents WHO, but he had to leave. But thank you for coming. And also want to thank the many people who are here to, this afternoon to attend this conference. Thank you so much. Dr. Susan Edionwe, otolaryngologist. Who would have thought that the diagnosis of, making a diagnosis of a disease is by loss of taste or loss of smell? We who would have thought that? But thank you for letting us know that all the senses are very important, you know. So, the TV, there's a TV panelist, there's a TV representative, I think the journalist who is here from Nigeria, I think health, journalist from Nigeria. Thank you for attending. And I just want to thank, if I miss you, please forgive me. I'm advancing age and I may be missing a few things, but that's okay. So thank you so much. Oh, the clergy, I really need to thank you for attending. Those, the clergy and other non-physicians who are attending this conference, you are so important because you will help us to carry this message to the people out there. We can't say it enough. It is important that there's no Lucifer in this vaccine. There are all sorts of stuff going on, but please help us to deliver this message. And please, all the people on this panel, take this information to your community because they need to know and they need to hear that this vaccine is what we have right now for this. Thank you all very much, and hope you have a wonderful, wonderful Boxing Day. Don't fight, and enjoy yourself. I'm Happy New Year to you all.
Thank you.
Thank you.
And our prayers to everybody in Nashville with the incidents that happened yesterday. Dr. Bamboye and everybody else in Nashville.
Thank you so much.
Thank you.
Thank you.
Bye.
Bye.
Thank you, everyone.
Bye.
Thank you.